always excites me to talk about the organisms, and I think even though I say the host is the most, these organisms are unbelievably fascinating. I think you heard 3 talks of how incredible the pathology can be and the tools that we have to deal with them. So it's open for discussion to all 3 of them, and we'll start with Neil. It's right up front, first one.
There we go.
Okay. Okay, you got it. Okay, good.
So first we just tour de force. You've done what, for example, in Coxie, one person has done more than a lot of people have done at all in Coxie. But I want to bring you back exactly to something that's what John proposed is the dimorphism, because I just stumbled on in Coxie the WOPR gene family that promotes dimorphism. And actually Anita Sill first identified that in histo, and she was on the paper with Ali Mandel and Mark Orbach for Coxie. So has that been looked at for Talaromyces, and it's there?
Yes, so is it on? Yeah, Alex Adrianopoulos have really spent his entire career looking specifically at this and identify tons of genes that are responsible for this dimorphism switch. And I'm not sure if they're similar to Coxie. I have not looked at that. But yeah, so it's been looked at.
Yeah, I would probably talk to Anita.
Yeah.
And because it's interesting, because this is not an Onogenales, it's a different organism, and yet to see if that same gene family were there.
Thank you.
We'll go to Jack.
Okay. Tom, one recognizes the importance of focusing on Candida auris for resistance in the epidemiology. Is the CDC paying any attention to the problem of azole resistance in Candida albicans?
Yeah, thanks, Jack. Yeah, I mean, I was asked to cover C. auris, but we are, of course, very interested in resistance in the other Candida species as well, and so we're looking into a number of different things that are happening in albicans and tropicalis and parapsilosis and glabrata, et cetera. So we have a small 10-site surveillance system that's been set up now for about a decade, where we look at about, I think under study there might be around 15% of the U.S. population. It's in 10 sites, and so that's where we get the majority of our data on resistance and species that are occurring. Now these are all candidemic, because we haven't been able to expand that beyond bloodstream infections, just due to you can imagine the challenges in getting people to culture and isolate and various other things, but that's always been on our wish list, is to look at a broader species population than just bloodstream.
The problem is really the mucosal candidiasis. It's an enormous problem.
Yep, I agree with you.
Mahmoud?
First of all, it's really great talks. And with respect to Tom, I really agree with you with your recommendations, trying to find methods for MIC and this sort of thing, that quick method to know whether it's resistant Candida auris or not. The other thing which you mentioned a little bit about decolonization. I mean, in addition to the MIC, we developed both guinea pig model, which is really useful for systemic drugs, and we published on Brexa, where we showed by giving it, because it goes to the skin, it's able in the guinea pig to clear or at least decolonize to some way this. But also we have a mouse model, and we published this work with the topical agents, APT, where it has it's different, actually with different formulations we use, and it is able to show that you are able to colonize. So having such a model, I think it will be as important or more into the in vivo situation. I don't know what they think.
Yeah, thanks, Mahmoud. Obviously, yeah, we were excited to see that FDA is sort of thinking about how to, approve a decolonizing regimen or a decolonizing drug, because they don't really have a way to do that. And so at least they're open now to thinking about that, because what is, and how do you define decolonization? Is it truly sterile, or is it below a certain level where we think transmission isn't happening? So I think this is a field that we should really get into a bit more, certainly now that we have C. auris, which is our poster child for something we need to decolonize. But as you know from your work, it's challenging with the microbiome. There's a lot of things happening there, and it's not just. And many of these, most of the C. auris patients, I would say, are colonized with multiple MDROs. So once that microbiome changes, it seems to make them more susceptible to having these other MDROs colonized in bacteria, and so then we have to deal with that challenge as well.
You know, you raise really very important point. And as part, like professor in dermatology, in the Department of Dermatology, we really have different ways to sampling skin and this sort of thing. So I'll be very happy to work with anybody who would like to see what's the best way to look at different compounds and see whether there's colonization and the effect on the microbiome. Thank you.
Thanks.
Yes.
I have a comment for the first speaker on the crypto immunopathology. It's a wonderful tour de force presentation. Your findings could actually be a great impetus to look at the dynamic state of immunity, especially these early strong hyperinflammatory and interferon gamma signals are a very well-known driver of subsequent co-inhibitory signals and exhaustion. Maybe that's a missing link in that immunopathology story that could have immunotherapeutic implications.
Yeah, I completely agree. So we think we can learn a lot from actually studying these hypervirulent strains, and really teasing apart how that immune response is being initiated and what part of it is actually a detrimental response, because we know that interferon gamma can be doing good as well, and so we suspect that there's a difference in those pathways. Yeah.
Thomas.
Once again, thank you so much for the excellent presentations. Tom, you very elegantly presented Candida auris as a challenge of infection control and antifungal drug resistance. How much of it is also a lack of resources and lack of ability of diagnostic capability in clinical laboratories? It's a difficult organism for many laboratories to recognize, to the point that it then propagates before one finally realizes that one has Candida auris versus a non-germinating yeast like Candida glabrata.
Yeah, thanks, Tom. Certainly, if you asked me that question 5 years ago, and you know, because you've been involved in talking to us about this over the years, I would say it's a real challenge. I think I'm much more comfortable now with the ability of we have this ARLN set up, this laboratory response network, that is readily able to speciate if need be, but honestly, a lot of the, as you know, the MALDIs and the softwares have been updated to recognize Candida auris. So I do feel like, at least in the U.S., we're in a pretty good place. Now, we could talk about other countries and other places. That's a different story. But I do think in the U.S. we're sitting good now. We've been able to really update that system.
Very good. Thank you.
Pete?
Yeah, I have a question for Kristen. Again, thank you all for wonderful presentations. So, Kristen, imagine that you could identify these hypervirulent strains. And I mean, that there is some, presumably there are some markers that if you were in the right environment, you could identify a hypervirulent strain. How do you think that should impact an individual's treatment, approach to treatment? What are your thoughts about this? Because it has to lead, and understanding that this is a very complex interplay between the host response and et cetera. What are your thoughts about that initially?
Yeah, so I'm going to drop a bombshell now that I was supposed to have mentioned in my talk and I didn't, and that is all of these hypervirulent strains are actually coming from patients that survived the infection. So they're the only set of strains that do not follow our trend. And we've got enough strains now that we've run through the mice that we're pretty confident, and that's actually what induced us to look at different mouse backgrounds to see whether this was a mouse background specific issue. And so I think this, in Cryptococcus, we use non-immune compromised mice. And so I think this really highlights the difference between an immunocompromised patient and a patient that's not immune compromised. And so what we suspect is happening is that in these immunocompromised patients, we're not seeing that big interferon gamma spike. And in fact, when we go and look at the patients, we don't see a big interferon gamma spike. And so I think this is really telling. We don't have a big enough population, or we haven't looked at a big enough population yet to know whether these hypervirulent strains might be predisposing a patient to IRIS when you do reconstitute the immune system. And so, I think in many ways, these strains are going to be just really fascinating because they're the only ones that we've seen that do not follow the trend of the same thing in the mouse that we see in the humans. So it's definitely fascinating.
Okay. All right, thanks.
So, Kirsten, why don't we use immunocompromised mice in our model?
Yeah, so my lab has asked the same question. And so we have developed and are actually testing many of our strains in a CD4 DTR mouse that we've been able to show mimics pretty well HIV patients. So we're testing those hypervirulent strains in that mouse now. Our prediction is that those strains will not be hypervirulent when you take the CD4 T cells away, but we're testing that now. Yep, yeah. But we do have a model that really nicely mimics it, and that we can use both for latent infections and also acute infections.
Ashraf?
I also would like to thank all the presenters for the outstanding presentations. Tom, I would like to share a story with you and also ask a question. So the story is, a few months ago, we've had a patient in the ICU that developed Candida auris infection, got treated, released, the room decontaminated, and the next patient occupied the same bed developed the same Candida auris infection, just to comment on the fact that you don't trust bed railings and all these things. So, I mean, we all now know for sure how tough it is to get rid of. So we also worked with you on developing the NDV3 Candida vaccine against Candida auris, and we published a very nice study in PLOS Pathogen. Now we're trying to actually enhance that vaccine, working on a dual antigen vaccine, second generation, paired with a much better adjuvant called CAF01 that we got from the Serum Institute in Denmark. Works beautifully in animal models. I would like to pick your brains on how do you see this vaccine being used against Candida auris? Do you think it would be basically better to use it as a decolonizer if it does decolonize? Or is it prophylactically used for patients who are predicted to have Candida auris, higher chance of getting infection? Or therapeutically with some antifungals?
Yeah, we've been talking about this vaccine for a while, and as you know, I was pushing this idea of using it to try to prevent and maybe decolonize, but prevent certainly C. auris infections from developing in those high-risk, very medically experienced patients that we know get it and get colonized, and we now know about 5 to 10% of colonization leads to invasive disease. You know, I've got lots of thoughts on that, as you know, and I'm excited to hear that you guys haven't stopped working, on it. And I was a little bummed that we couldn't get anyone to bite on that first idea of using it in this context. But it's a new way of using a vaccine, as we know, in sort of this, in this hospitalized or long-term care facility type of way, and with people that are quite medically experienced and sick, and so I think that some of the hurdles of getting over that, whatever you want to call it, fear or challenge of using it are still there. But I think we need to continue to be creative and thoughtful. I mean, we don't have a fungal vaccine, as you know, approved in any way, shape, or form. Although thankfully there's some movement in the endemic space with Coxi now. But yours was the first out there to try to address this, and I think it's a different way of using a vaccine, but I think it's worth exploring. I mean, we certainly are used to vaccines now since, billions of mRNA vaccines have gone out. But using it in this sort of way is still a new concept.
Yeah, just to comment that about the vaccine itself. We haven't stopped, actually, thanks to the NIH. We've gotten this good R01 grant that's allowed us to actually develop that second generation vaccine. I also would like to say that it is effective against Candida albicans, disseminated candidiasis, VVC in the animal models, as well as gram-negative. So we can see protection against Acinetobacter, KPC, and Pseudomonas. And this is because of the inclusion of HYR1 in addition to the ALS3. So HYR1 has structural homology with heme agglutinins as well as AMP-A on gram-negative. So I'm going to be talking about this in ISHAM as well.
Great.
John.
So, John Rex, I want to throw a cautionary note for everybody who's listening to the conversation about decolonization and prevention of infection and developing drugs or vaccines in that pathway. This is my cranky drug developer perspective under the rubric of why do they do that or why do they say that? And what I want you to all do is look really closely at the guidance documents from the agencies, and if you don't know how to find them, ask me, I'll show you. The endpoint is never, ever, 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 ever clearance of the organism. Ever. Okay? Because you can't document that. How much of the body do you have to biopsy to be sure it's gone? And no one has ever come in complaining, oh, the C. auris in my nose hurts like hell today. You don't say that. Instead, you say, I'm sick. I've got fever or whatever. And the endpoints, and you can disagree with this if you'd like, but when you look at what the agencies are looking for endpoints, it's prevention of symptomatic diagnosed infection. It's not clearance of the axilla. So there's not a better culture test that's going to be the way that you get something developed. Again, you can disagree with that if you want to, but you need to understand why the agencies are saying that, because otherwise all you're going to do is hit your head against the wall. And I think this is actually a big community problem. I think that we actually have reached a point where developing certain tools is scientifically interesting and almost impossible with our current rule set. And if we're going to change that, we actually have to start talking the way the agencies think about developing drugs. So that's just my theme song. And I think there's a lot to unpack. I could give a lecture for an hour about this, about the basis for it. But the core point is that right now, all drugs are approved based on an endpoint based in how a human being feels, functions, or survives. That's the mantra, feels, functions, or survives. So even all the COVID vaccines are developed because they prevent you from feeling bad, not because they keep your antibody titers from going up. So keep that in mind when you're thinking about this, and be sure you understand the failures, and a really good one to look at is the failures of the development of the vaccines for Staph aureus. For Staphylococcus aureus, you would think that you ought to be able to do that. And there have been so many attempts, and they have failed in some very interesting ways, including a recent enormous effort by Pfizer to develop really one of the best looking vaccines you might have ever seen, and they stopped. And so if you don't know that story, you're making a mistake. So that's my cranky drug developer comment for today. But please, we need to change the conversation. You have to change it by knowing what the other side of the table is thinking about.
Yeah, and I will just comment, being in an agency, that we've been engaging the other agency on this topic, John, for quite some time, and had a lot of private conversations with them about endpoints, about decolonization. And that's what this workshop last week was all about. It was about changing that. But you're right. Right now, if we're trying to decolonize, we got to decolonize so that they don't develop a disease. And that's not why we're trying to decolonize. It is ultimately, but we're never going to prove that in any kind of a decolonization sort of study. So we are definitely engaged with them on this. I think it's been 3 years I've been having conversations indirectly, and our agency with their agency has been having conversations. And I agree, we're not at a point where, but the fact that they're talking about it and thinking about changing things, to me, is a good sign, and we should continue to talk with them about it.
Yeah, the medics are privately sympathetic to the point, they get it, but it's up to us to bring them an answer that works from the regulatory side, not up to them to create it.
Okay, any other questions? They said in the back, I'm over time, that's fine. That's why I'm up here, I'm the moderator, I make the time. And I'm going to spend a couple minutes just talking to my panel. And again, when we're finished, I'm looking at my clock. So instead of having a half-hour break, we're going to have a 15-minute. Oh, we got another person. We may have a 10-minute break. But then we get
Yeah, there you go. Well,
Peter.
I'll go for a while. I got two questions, but I think I'll hit the first one. Well, I can't resist. Kirsten, on your, we do know that AJs are defective in complement, and complement is coming up. Mihalis has done some work with other fungal infections. There is a complement sufficient AJ that was developed. Have you used any of those? I know probably the CD4 is the way to go anyway. But these mice are not immunocompetent. They're so weird that they get crypto, playing around. They play around the dirt all the time. Have you ever done the complement sufficient one? Or you're just going to go to the CD4 and not worry about it?
No, so we actually, we know that the AJs are, the line that we're using is the complement deficient line, which was one of the reasons why we were so surprised to see that the immune response that they elicited. And yes, we haven't yet tried the AJ complement active line. What I showed you was really just our first pass. And so now we're really going to have to tease apart a little bit more. So we're not going to go directly to the CD4 mouse. We were definitely going to test it in the CD4 mouse because that CD4 we think is a pretty good model for what we're seeing in the HIV patients, and also because then we can match that with some more human type studies. But yeah, the goal is to figure out what it is that's different in these AJ mice and see if we can drill down to what are the important aspects of the immune response that are actually altering when you're changing your clinical strain.
Because it might say something interesting about a subpopulation and complement in those HIV patients as well.
Yeah. So I think this is going to blend really nicely with the other studies that the immunologists are doing to try to identify the deficiencies on the human side that are impacting outcome. I think it'll be really interesting to start comparing the pathogen and the host at the same time to see how that interaction is actually creating the phenotypes that we see.
Oh, great. One quick question on Telleromyces. Love your work, sounds great. You are doing MICs, you're not doing fungicidal assays, but yet, and you kind of disproved your assay in a way because ITRA looks really good in that and it doesn't work. And you don't get clearance, which is a cidal assay. Have you considered doing a cidal assay, even though it's a real pain in the neck to do, as opposed to MICs?
If I have a very good reason to do that, I will. A strong belief in that drugs, I will. It can be done, like you said.
Yeah, it's a pain.
It's just very labor intensive. It's not something, our purpose is to develop a method that can be standardized, it be objective enough for resource limited setting to do without fancy, so this is more to screen, but if I have a very strong conviction about certain pathogen, yes.
Because you made a bad drug look good, right? Because ITRA looked really good. It works a little bit, but you don't like it.
Well, amphotericin B, MIC is not great.
No.
For anything, and it worked like a charm.
Because it's not really an MIC, it's a
right.
suspension, it's not a concentration.
And that's why we need an animal model, and that's why
that's key, yes.
We need to run animal studies.
But it's hard for an individual. Sounds good. Thanks, very good.
Thanks. So I'm going to finish up and look at my clock. I got a minute and a half. I'm not going to ask Twee anything because I think she covered everything I know. We talk about it extensively. Kirsten, I want to emphasize on an editorial point to what she's seeing here. Many of you are clinicians in the audience. There are new tools out there. She has developed these tools. She has worked very well with people out in the clinic, and that's extraordinarily important. She's now come to the point of mice and men, trying to put these things together to come up with strategies of understanding these organisms. For Pete asking the question of whether it's going to be important that we're going to identify things that someday, instead of MICs, we may actually have a genetic profile that determines an organism that may be more virulent than another, both in the human and in animal models and stuff like that. What she demonstrates a little bit is that it is complex, but there are tools out there to do that, and she can continue to interact with the clinicians and get information. Like for us, it actually turns out our connection endpoint is not death, because we maybe don't have enough patients, although we have 300 or 400. It actually is quantitative organisms in the CSF. We use different animal models than they talk about. I went through all those inbred mice and said, I'm wild type. Wild type occurs in humans, right? So we went to CD1 rice that we actually use as our the standard look for our endpoints in mice. All this stuff I want to emphasize is the beginning of these things. They are complex, but we do have the tools. And if scientists like her can interact with people like you and stuff like that, this is doable over time to understand what makes these organisms tick. And finally, for Tom, just a question. As a clinician going into these rooms, what should we do? Is this like C. diff? I mean, it seems like what happens if we ever get it in our hospital, everybody would be gowned and gloved and everything would be just all over the place. The patient would never be seen, that's for sure. But is it really, does it need everything? What does it really need? I mean, because you're not a colonizer and stuff like that. We're not taking maybe from person to person, or maybe you're doing that thing. It seems like it's the place where they're at. And so, what should be our criteria as clinicians? Should we still be in those gowns and gloves and masks and booties and everything else to take care of a patient with C. aureus?
Yeah, I mean, I think that's a big question that we're asking ourselves at this point now, seeing how, what you guys have seen on these maps over the last decade and what we're seeing now in the U.S. So I still think, yes, you should do that, John, for the time being. I think that we know we've seen some data, and we know that patients discharged from the hospital that are positive with C. aureus can go out into their homes and they can remain positive for months. Although we're not sure what the dynamic of transmission then is within the community and whether then they bring it back into the hospital or not. So I think we still, that whole element is unknown, but I do think that for the time being, we know we get these outbreaks, we know we get these clusters, we know we get the transmission. We're worried about highly drug-resistant transmission, which we've now seen at least a couple of times. And so infection control does work to prevent those kind of things from happening. And so I think for now we have to stick with that. But is this going to be just like another MRSA, where it's just sort of widespread and everywhere, and we don't do those kind of precautions with MRSA anymore? So I don't know. I mean, is that where we're headed?
Well, again, thanks, because we do that a lot. Actually, those MRSA, we still do that at our place. Massive amount of gowns, massive amount. Okay, so I've got about 13 minutes or so. We're going to stop here and come back around at 10 o'clock. And so come back, and thanks for all your questions and various things. And for the people that Pete has listed, can they come up here so we can have a picture taken? And I want to thank our organism people, because I think they did a great job.